Hey everybody, welcome to the Pediatric Asthma Nightmare Case. Let's jump in and get started. Objectives. We're going to discuss the introduction case study. We're going to look specifically at treatment considerations in the asthma patient. And we're going to analyze ventilation strategies for that specific type of patient. Let's start off with our case. We have a 10-year-old male patient, 30 kilos ideal body weight, history of eosinophilic asthma that was diagnosed about 2 years ago. Current blood pressure, as you find him, BP 103/69, heart rate of 134, current respiratory rate of 28, breathing on his own, and an SpO2 of 94%. They give you the ABGs, and you notice that pH is 7.15, PaCO2 61, bicarb 24, and our PaO2 is 127 with a normal base excess of -2. They've given a multitude of medications. They have him on a albuterol neb ×3, obviously an ANA. MAG drip is started. They've given him 3 doses of IM epi. And the patient just isn't getting better. You're called to transport this patient. So let's dive in and discuss this case. You're given the chest x-ray. You sit there and look at it and notice a few hallmark classic signs of that obstructive lung pathophysiology. Notice that we have a patient, if we look at this from the rest in peace mnemonic, number 1 rotation, is this patient rotated or are they symmetric? And I definitely feel like the patient is symmetric. Do I have good inspiration? Are the lung fields full? And I would say absolutely. And then do we have good penetration? And all that it means is can we see our bony prominences? Can we see our dense areas? Can we see our vertebral spine, our clavicles, our AC joints, etc.? Can we identify the ribs? Can we identify those classic markings? And I would say yes. And then the last thing we look at is this an AP or a PA view? And this is definitely a PA view. I do not see the scapular markings in the lung fields. And so then we look at this from the pathophysiology standpoint, and we notice that we have hyperinflation. Our lungs are definitely hyperinflated. Heart silhouette is somewhat narrowed, not terrible. And we know with a PA view, we should have a normal size heart. 50% of the entire chest width as far as ratio goes. Do we have any flattening of the diaphragm? Well, we know that in a normal patient, your right diaphragm margin is going to be higher than the left, and we can draw a line across here, and we definitely do have a difference in height. So our diaphragm flattening is not as pronounced as maybe somebody we would see in chronic COPD or a patient with long-standing asthma years and years and years. So we definitely have hyperinflation. If we go back to our case, the MD elects to intubate our patient. And so we perform rapid sequence intubation. Again, I really try to use the whole terminology of damage control resuscitation or resuscitative sequence intubation. They give ketamine at 30 milligrams, rock at 30 milligrams. So again, they're using 1 milligram per kilo for both of those. We know for pediatrics on the rock side, you can go as low as 0.6. They chose to use a even 1 milligram per kilo. Intubation was successful, first pass attempt, 6.0 ET tube, 18 at the teeth, end-tidal CO2 reading with a good waveform at 52 millimeters of mercury. You give an additional dose of ketamine for pain and sedation at 15 milligrams, so 0.5 milligrams per kilo, fentanyl at 30 mics, and you decide to start a ketamine drip at 1 milligram per kilo per hour. Now remember, the ketamine does have beta-2 properties, will assist in some potential bronchodilation through the activation of those beta-2 receptors. Now let's look at our eosinophils and really dive into that. If you remember from the case presentation, I highlighted that this patient has a diagnosis in the past of eosinophilic asthma in the past 2 years. So what does that mean? Well, when we look at asthma as a whole, asthma comes into two forms. Number one, neutrophilic. That's 95% of the population approximately. And the other 5% is eosinophilic. And that is extremely difficult to treat. And so when you have an eosinophilic asthma, confirmed history, understand that your treatment methodology, even if you do everything correct, these patients are going to be very difficult to manage. They are resistant to medications, resistant to that pharmacological intervention, really from a wide perspective. And so let's review really where those eosinophils come from. They come from our white blood cells, right? And so we see on the screen this mnemonic I'd love to teach off of, and this is how I remember white blood cell counts. Never let monkeys eat bananas, and that stands for neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And you could also add a sixth one, and that is bands, but really bands are only present in certain situations. So you can see the normal percentages here, and really what we want to focus on is the eosinophils. Where is a normal number? Eosinophils really represent any parasitic or allergic reactions, and that's where you're going to see an increase in eosinophils. A mild increase, it gets up to 8-10%, usually not as worrisome. It could be benign, it could be based on stress, it could be based on those little things. But when you start seeing bigger numbers in those eosinophils, that's where you need to be questioning your patient. If your patient doesn't readily give you the history, hey, I have eosinophilic asthma, or family is not able to do that, then this is a clue. What I will also say is family is going to know, right? Physicians are going to be able to highlight this when they're diagnosed that this is a severe form of asthma. It's not something to mess around with, and families usually are very, very good at the history side when it comes to these diseases. So to recap, right, 5% or less, big inflammatory response systemically. We're talking both lungs. And this is refractory, as I said, to medications. Your medications are going to have little to no effect on these patients. How do we treat these patients? If we think of this from the mechanical ventilation standpoint, there are a few things to highlight. Just from a standard approach, in the adult population, we teach 6 to 8 mils per kilo. We use a lower respiratory rate in the adult population. We use 10 to 12. But because this is a pediatric patient, we're going to increase that. We're going to increase that to 14 to 16. PEEP really is not the big issue. These patients usually have auto PEEP. There's literature out there that might support increasing the PEEP, but I would be very cautious, and I would, be more conservative in the initial vent preparation. And then ID ratio for that standard pediatric patient should be in the range of greater than 1 to 3. Now, we're going to challenge that as we move through this case. I just want to make sure that we understand these are starting numbers. These are not going to be numbers that you are dead set on. We start in these ranges and we move fluidly based on what our patients are doing. What's the best mode of ventilation? Is there a best mode? Is there a best way we deliver a breath? An example here is the Hamilton T1. Is the Hamilton able to give a volume breath? And the answer is no. If we highlight this area at the top, volume controlled adaptive, all this means is the SCMV plus, the SIMV plus, those are the underlying modes. Basically, SCMV plus is assist control. SIMV plus is your SIMV. But those are volume adaptive. So think of it as PRVC, pressure regulated, volume targeted. When you start with either one of those modes, you're going to set a target tidal volume. The ventilator in the background is adjusting the inspiratory pressure to achieve the exhale tidal volume that you're looking for. If we contrast that and we go down to this second line, we see pressure controlled or biphasic. We have PCV plus, that is going to be pressure delivered in an assist control breath. And then you have PSIMV plus, and that is going to be basically pressure SIMV. Again, The difference is in this case, you're going to set an inspiratory pressure, an ultimate PIP. You're going to have to actually watch the exhale tidal volume, and you're going to have to regulate the pressure up and down yourself to achieve the exhale tidal volume that I have highlighted here. So these two parameters that we have highlighted are areas that you're constantly adjusting to target the tidal volume that you desire based on ideal body weight multiplied by 6 to 8 mils per kilo. When we contrast that with, let's say, the Revel ventilator, the Revel ventilator is a volume or pressure delivered ventilator. You can pick each one. And so I guess the point here is there's not a hard, fast rule. What I would say on the Hamilton is you only have one method, right? You have to use a pressure breath. It's just in how you want that done. Do you want the ventilator to regulate that for you to achieve a tidal volume, or do you want to turn the knob up and down? I personally like to turn the knob up and down and adjust it myself. That's just me. If I'm using a ventilator like the Revel in this patient, I'm probably in this type of patient going to go to a volume breath. I think it gives us a few advantages. And I think it's a little bit more simple in this type of patient. Why is that? Because you got to remember, as our patients become more constricted, their airway caliber becomes smaller and smaller. The standard method of us delivering a breath, we have to understand we're delivering an inspiratory time and an expiratory time. And based on that standard setup, if we set an inspiratory time of, let's say, as we see on the screen, 3/4 of a second, so 0.7, the rest of that is basically your E time. As your airway caliber becomes smaller and smaller, you're reducing not only the time it takes to deliver that breath, right? We're 3/4 of a second, but we also have a small airway. And so you have to be able to generate enough pressure to deliver enough of a breath to fill the lungs based on the lung compliance. If we go back to our case, again, 10-year-old male, now intubated, fully sedated, pain management taken care of. The crew is now in transport, and they're noticing that the patient's end-tidal CO2 is increasing. Remember, we were in the 50s after intubation. Blood pressure 103/69, heart rate 134. Notice there's no change. Respiratory rate underlying of 15. And end-tidal CO2, as we see, is 68. So the crew, looking at that end-tidal CO2, decides, hey, we don't want this patient to become more hypercapnic. They're looking specifically at the end-tidal and focusing all their attention on that end-tidal. But we have to understand, we set a respiratory rate in these patients for a few reasons. And that's because we want a lower respiratory rate, which automatically allows for a longer expiratory phase. If we then increase the respiratory rate, we automatically decrease the expiratory phase. So if you have an end-tidal CO2 of 68, what changes should be made? Should any change be made? Is it important that we focus on that end-tidal CO2? And what I'll challenge you is to say no. End-tidal CO2 is a reflection of what's going on. If it's climbing, they're becoming more hypercapnic. Is there other reasons why? We all know that your patient can live much better in a hypercapnic state than a hypocapnic state. We've had multiple studies actually prove that lung protection, specifically in ARDS, is more important. Reducing driving pressure by reducing our overall tidal volume in minute ventilation obviously increases our end-tidal CO2, but those patients actually survived. So why is that end-tidal CO2 climbing, and what can we do to make a change? So let's look at the math and break this down to make this make more sense. Obviously, ID ratios 1:1 all the way to 1:4 are standard. We also have to understand that really in pediatrics, the younger pediatrics, we tend to focus more on just that I time. But that I time only tells you one part of the story. We got to understand the math. If you set an I time of a half second, what is the E time? What is the impact of that exhalation phase? And so, for example, remember the patient has a respiratory rate currently at 15. If we simply take a calculator and we have 60 seconds in a minute, we divide that by 15 breaths, that gives us an overall cycle time of 4 seconds, meaning that every 4 seconds, the patient has to inhale and exhale. How do we divide that up? And the way I always think about that is this horizontal line here. And all I'm doing is moving this vertical line back and forth. If I move it to the right, I'm increasing the inspiratory time, decreasing the expiratory time. If I move that bar to the left, I'm decreasing the inspiratory time and increasing the expiratory time. So it's just all based on understanding the math. So right now we have a patient that has very low ability to generate enough tidal volume, right? We only are giving a small window for them to inhale. They're using the Hamilton. They're using a pressure breath. Do you have enough time to generate enough pressure that's going to give enough volume based on the airway caliber? Or they're using the Revel and they're choosing to use a pressure breath. Same thing. Would a volume breath change anything? Ultimately, you have to have enough time to deliver enough breath based on the airway caliber. So how could we change the math here? What if we flip this and we change this to, for example, a 1-to-1 ID ratio? And why would we do that? One of the areas we have to understand is this patient has dynamic hyperinflation and obviously has an expiratory flow limitation, not able to exhale properly. But what also happens is that we end up seeing an incomplete exhalation phase that starts compounding on itself. Does that also start contributing to an inspiratory failure? And that inspiratory failure, guys, is what we have to start focusing on. That's the missed element in these patients. We spend all this time focusing on that expiratory phase. Do we spend enough time focusing on the inspiratory phase? Again, if the airway caliber is narrow, if we're constricted, do you have enough time to generate a breath that's going to give a minute ventilation that's going to allow for, we'll say, normal capnia? Obviously, this patient is going to be elevated, but we don't want to see it climb. What's going to happen if we increase that respiratory rate? That is really old teaching. And if you learn like I did as a new paramedic and we started using end-tidal CO2, you're taught in a very basic way. If your end-tidal CO2 is high, if you're hypercapnic, it's because you're not breathing fast enough. Your minute ventilation is not adequate enough. And so we're taught to do what? We're taught to speed up our rate. In contrast, if you're hypocapnic, if your respiratory rate is super high, your end-tidal CO2 is correspondingly high, we're taught to slow down our rate. And I really, really caution you to forget that teaching. That should be probably the fourth or fifth thing that you consider. So how can we use our math and our mind to both impact the expiratory phase, which we know is a factor, but also improve the inspiratory phase as well? I want you to notice that the patient is getting a tidal volume exhale, they're in pressure, of only 72 mils. A 30-kilo patient at 6 mils per kilo should have 180 mils of exhale tidal volume, or right around there. So they are significantly low, and that is a great indicator that they are not generating enough time to fill the lungs. Either the pressure needs to be turned up, the PIP needs to increase, or our time spent during that inspiratory phase is limited. And so we have to fix this. So what do they do? They increase the rate, right? They go back to the basics of what they were taught years ago. They decide to increase respiratory rate to 36. Inspiratory pressure is 15 with an overall PIP of 20. FiO2 of 70%. Is this an oxidation problem? Absolutely not. But as we start having a patient decline, we start having a poor ability to inflate those lungs, our minute ventilation decreases. Yeah, eventually your SpO2 is going to fall. But remember, don't focus on that. Focus on minute ventilation. Focus on allowing for both inspiratory, expiratory phases. Now, if we look at the vitals, notice blood pressure is down to 88/49, heart rate of 130, respiratory rate of 36, and our SpO2 is hovering right around that 90% range. Again, don't focus on that. End-tidal CO2, though, now is 98. So why? This is a great example. Picture this in your mind. They did exactly what we probably were all taught in the very beginning. I know I was. End-tidal CO2 continued to get worse. It's jumped up 30 points. It's because now they've never addressed the inspiratory phase. Inspiratory phase is still very short. They're still not getting enough volume into the lungs. They are hypoventilating the patient. So why is that? Why has end-tidal CO2 climbed? Picture that. Well, look at the tidal volume. Tidal volume is significantly low. We're not even reaching half of what it should be. So they are trying to go back to the basics. They've increased that respiratory rate. They've doubled it, over doubled it. The response has not been what we thought. Because what they've done is they've now decreased the expiratory phase. So they're not allowing enough time for exhalation. They've never addressed the inspiratory side. They're not generating enough pressure. They don't have enough time to generate a pressure to fill the lungs enough to generate a tidal volume. Now let's refocus our mindset. What should they do? Well, a great example, guys, is increase the time during inspiration. They obviously have an end-tidal CO2 of 98. Notice now our rate is reduced down to 15. We have an improvement, an increase in tidal volume. We're still not even close to where we need to be. PIP could definitely be much higher. And that's the thing you got to remember is in these asthmatic patients, you may have to go over that 35 centimeters of water or where we keep that threshold, right? You might have to generate a bigger breath. You need to understand your ventilator. You need to understand our high pressure limits and where we can go. Hamilton peaks out at 60. So understand where your thresholds are. Blood pressure 88/49 again, heart rate 130, respiratory rate of 15, SpO2 unchanged, end-tidal CO2 98. So what should we do? Continue our sedation, continue our pain management, keep our patients comfortable. I definitely advocate in this type of patient to paralyze your patient, but remember to continuously sedate and give pain management. It's real easy to have long-acting paralysis in place and forget to do that. And I definitely think this is one type of patient that I would advocate for long-acting paralysis. So let's look at the math. How can we manipulate that ID ratio? So if we look at the ID ratio now and look at the math, as I said before, we go down to a 1-to-1 ratio. What does that look like? Well, we have 60 seconds in a minute. We divide that by 15 breaths. That's what he is currently set at. And notice what the math does. We have 4 seconds of cycle time. We're giving equal weight to both the inspiratory, expiratory phase. And now we start seeing improvement because we have to, again, not get so tunnel vision to think that just because they're obstructive lung patients that we only focus on the expiratory phase. We should focus on now both sides. We're giving equal weight. We're going to now start looking at improvement. Are we getting a better overall exhale tidal volume? We should start seeing improvement because we're allowing more time, more volume, more pressure generated to fill those lungs. Those lungs will fill based on the compliance of that patient and the lungs currently based on their pathophysiology. What are some other considerations in this case? Understanding your ventilator. Again, every ventilator is a little different. The Hamilton does a great job in using its technology to account for any mechanical dead space in that circuit, but understand that really truly mechanical dead space is about a volume breath, a true volume breath. And it's everything previous to the flow sensor. And so a great tool is to remember an adult circuit, you lose 2 mils per pip in that circuit. Again, only in a volume breath. Pediatric circuit, around 1 mil per pip. Use your manufacturer as a guide. This is just a quick overview. Everything we put, though, outside of that flow sensor, so distal to the flow sensor, does account for mechanical dead space, and that is going to impact your overall volume. So again, distal to the flow sensor, as we see here, anything you put outside of that flow sensor is going to contribute to mechanical dead space. So think about viral bacterial filters, 90 mils a minute. That's going to be about 1.5 mils a second of loss. Obviously, a bigger patient, adult patients, bigger pediatric patients, not a big deal. The smaller that pediatric gets, you get into the infant and neonate range, 1.5 mils a second is a big amount. You think about the whole HME. You think about end-tidal CO2, which is a gold standard. All of these contribute to your overall mechanical dead space and will reduce that overall volume. So in a volume breath, you just have to understand that loss can't be given back. You can add more volume on your tidal volume to contribute to that. But is that going to make a big difference? In a pressure breath, probably going to be a better situation because remember, in a volume breath, in like the Revel ventilator, the Impact, the MV, everything previous to the flow sensor is mechanical dead space. You've got to also add that. In a pressure breath, that is not the problem. It's everything outside of that flow sensor. In summary, the decision to use volume versus pressure really is about the patient, and it's also about the equipment you're using. Remember, the mode of ventilation really isn't the biggest decision. Whether you're using assist control or SIMB, if you have a patient well sedated, if you have a patient paralyzed, for example, it's going to do the same thing. Either mode does the same thing. PEEP application in the setting of dynamic hyperinflation really is controversial. You need to consider both sides. I would say go conservative. Anatomical dead space, right? The volume you deliver that doesn't contribute to gas exchange, that gets trapped in the chest, causes that auto PEEP increase, that severely impacts hemodynamic status. And that mechanical dead space really is the silent killer in pediatrics, especially if you're using a volume breath. The smaller the kid, the more you should use pressure. But understand, if you're using the conventional 1:3, 1:4 IDE ratio in a pressure breath, are you giving enough time to generate a pressure to fill the lungs enough to meet the minute ventilation and overall tidal volume requirements? If you guys have any questions on this case, guys, please email me, eric.bauer@flightbridgeed.com. There is a lot of good information in this type of module. These are really low occurrence, high acuity situations. You couple that with the eosinophilic asthma and you couple that with a pediatric patient, really stress is elevated. And so if you have any questions, please email me and I will talk to you soon.